Hi there, my name is Arlene Maxim, and I want to thank everyone from the association who's invited me to present this session for you today. I think it's something that most everyone is excited about, talking about technology and the use of telehealth and home health. I've been a consultant. I've been in home care for a little over 35 years now, and I do consulting nationally, and currently I'm working with Axxess as a clinical consultant and working with them in their education department. And it's a pretty exciting time for us right now because we have so many new changes. Of course, the final rule just came out last Thursday, and we're all still probably trying to get through that. So the RAP issue and a number of issues seem to be top of mind, but we can't forget that we have a business to take care of. And so using technology as part of your business is going to be something that's going to be very exciting for you, can save you money, can save you time and save on your recruiting costs and the retention of your staff. So we're going to go over some of those things that make telehealth and using the use of technology helpful for your agency. And we'll be talking about how technology is now an integral part of the home health agency success and staff retention. Little did we know at the beginning of this year that we would be we would encounter a virus such as COVID-19. We thought in January, and I'm sure all of you did, that PDGM was going to be the most difficult thing that we were going to have to handle in the year of 2020. But as it turns out, PDGM has just become an afterthought for us. And we are probably seeing some results from the impact of PDGM now. Of course, the COVID-19 has not helped at all with our saving cost and redoing our staffing models and that kind of thing. So a number of agencies have indeed taken on telehealth as part of their, not only their plan for PDGM, but also their plan for COVID-19. I don't know if any of you were watching some of the rallies last night, but even the president was talking about the use of telehealth in healthcare in general. So I think it's pretty exciting that we're getting national recognition, not only as for what we do and its relationship to COVID-19, but also there's perhaps a chance that we might be able to use telehealth in the future as part of our overall business. Of course, right now we can use telehealth as a cost, as an administrative cost for ourselves in the home care agency, but the cost for the actual technology is not reimbursable. So we are hoping that perhaps next year, I know that there's a bill in the House and I think also the Senate that might pass before the end of this year. And so hopefully in 2021, we may see some direction toward reimbursing us for the telehealth programs. We're going to talk about the areas in which telehealth remote care monitoring can improve the practice of your home care in general. There are a lot of things that can really change the way you actually provide services to your patients in the home. So we're going to talk about that, explore ideas for how to effectively promote the use of technology and improve patient outcomes. When we started in 2020, I would hear rumblings from agencies saying that, oh, you know, telehealth is nice, but patients just aren't going to use it. Well, as it turns out, for the most part, patients really love it. There's a couple different types of telehealth. There's some that collect just the data about the patient. There is remote care monitoring. There's something called BYOD, where they can bring their own device, and so they can be very mobile. So some of the states, such as Texas, is one of the states I know that actually reimburses for telehealth. And with that, you can use your telephone, your smartphone. And with patients that are on Medicaid, they can be very mobile and still have the telehealth with them and be able to communicate with their providers on an ongoing basis, whether it be their physician or their home health provider or whatever. So there's a lot of exciting things going on out there. There's improvements going on all the time. So we're going to talk about some of those, and again, how you can integrate this in with your own home care agency. Okay, there's something called a silver tide that we've all been experiencing, and that's causing a growing healthcare demand. So as you've all heard, we have a number of people reaching Medicare age very rapidly. And it's estimated that 1 in 5 Americans are going to be seniors by the year of 2030, and we just don't have enough clinical staff to pick up the care that's going to be needed for all of those folks. 88.5 million people will be 65 by 2060, and the healthcare expenditures are going to reach $4 trillion by the end of 2020. We're hoping that the use of telehealth technology during this past year, whether it be in the physician's offices or in home health or in related to hospital assisted living care, whatever, we're hoping that that number may go down, particularly because it's actually saving dollars for the healthcare system. This next slide just shows you the rate at which the seniors are aging and the thousands of folks that we're going to be responsible for in the next number of years. And again, I just got to say that we just don't have enough clinicians coming out of school to take care of the patients the way that we used to. And some of the schools are not training the staff in the types of healthcare that's provided in the home. So telehealth can be very, very helpful in making adjustments to the care that's going to be needed in the home, the teaching, and actually teaching patients and their caregivers to actually take care of them while we can give them oversight from afar. So the average age of a nurse right now is 50 years old or over. So a number of the nurses too are going to be retiring. So that's going to cause even a bigger problem. It's estimated that 70,000 nurses are going to retire annually. So to keep up with the aging population, the nurses are going to need telehealth because the telehealth services are going to be an adjunct for the actual nursing visits. Again, right now we cannot be paid, we're not paid for telehealth, but NOC I know is working very hard to actually get the cost of the telehealth visit not only paid for, but we would be able to use those telehealth visits as an actual visit. So the agency itself would save on mileage and a number of other things. So telehealth creates a touch point for our patients. We can actually communicate with them. We can do virtual visits. And again, there's a number of different types of telehealth out there, but the virtual visits are really great because you can actually see what's going on. I actually think that intake would be benefited if they use some type of technology to actually visualize a patient when they're doing intake from the office, which would give the start of care clinician, whether it be a therapist or a nurse, an awful lot of information about the patient that they may not have if they just go directly to the patient's home and don't know exactly what's going on with the patient. So I think there's a lot of uses for telehealth that we can look at as expanding what we're actually doing already in the home. So clinician turnover is another problem. So the average age of the home health nurse right now is 19 months. That's pretty interesting because there's so much work that's included in hiring and retaining home health nurses and therapists. So the average cost of turnover of a nurse ranges from $37,000 to $58,000, and that's a significant number. And that would include the training, their orientation, the preceptorship, all of that all those things that are included in hiring a new nurse and again retaining them. And again, with the millennials, their turnover is going to be higher because they don't engage probably as deeply as we have in the past. Some of the nurses that are in some home care agencies and some hospice agencies have been there for 20 and 30 years. And we probably aren't going to see that type of nurse again for a while until something changes. But right now, the cost of the turnover is just staggering. So again, you can see here with the occupation projections, nurses are the folks that we need the most, and we're probably getting the least numbers coming out of schools. And so we need to do something to augment what's not being done by the physical contact that was typically done by the registered nurse in the home. So with technology, we can actually increase productivity. We have to understand that nurses are not computers. They can't be working 15, 16 hours a day. Now, one of the pet peeves I have as a home care consultant is that the nurses are not taking advantage of the on-site ability to do documentation, the point of care documentation in the home. And that was the whole impetus behind computerized electronic medical records back in in the year 2000, I'm sorry, in the year 2000 when we went to Oasis, and the EMRs just started to spring up all over the place. And the selling point for that was they could do point of care documentation, and they wouldn't be doing that handwritten documentation at home for hours and hours and hours. And as it turns out, what's happened is we have not point of care documentation, but we have point of kitchen, point of airport, point of everything else but point of care. And so I would encourage people for productivity's sake to do the documentation in the home. And the other thing about productivity, if you have done any research on studies on memory, you find that your 20% of what you learn at the patient's home is lost every 15 minutes you're outside the home. So it's extremely important that you try to do that documentation as close to the point of care as possible. The increased productivity will take place when the nurses actually get to rest at home. Most of the arguments I find from nurses that are leaving home health completely is they're tired of doing the documentation, not being able to spend time with their families and that type of thing. And in hospitals, of course, in nursing homes and other healthcare settings, we can punch out at 5 o'clock and we're done. And home health is not necessarily always like that. So the agencies that plan on improving productivity standards this was based on a study that was done during PDGM. About 305 agencies were, and this was out of 400 home care agencies, 305 were expecting to do something that's going to change their productivity. Now, this was all done, of course, prior to COVID. Only 95 of the agencies, I'm sorry, I switch those. There were 400 agencies. Only 95 of those 400 were going to make productivity changes as a result of just PDGM. Now with COVID and the changes we've had to make with that, I'm sure that's changed, and some of those productivity standards are really skewed right now. Hopefully we'll see some leveling off next year. So the causes of the turnover, again, increased workloads. Like I said earlier, nurses aren't computers, so we can't keep them going 14 and 15 and 16 hours a day. So they have increased workloads. The documentation requirements are significant. CMS talks about Paper Reduction Act, but I see more and more documentation that's needed, partly because the clinicians are not trained properly in the beginning on how to do computerized documentation, which is another thing I would encourage you to do as you think about just technology in general, is to train your staff on how to not only answer the OASIS questions on your EMR, but also include the narrative that is going to support the OASIS answers that you've given. There's a surge in workload. Some of it has to do with the technology. The nurses aren't sure how to use the technology. The drive time certainly is tremendous, and it depends. Some of this has to do with the location you're in too. There are some areas of the United States that don't have as much drive time as others, but certainly drive time is taken into consideration when they think about their workloads. And then no visit activity. So you're not actually doing hands-on activity, but you're doing a lot of documentation. The use of administrative staff to cover visits. This has been a problem that we've really encountered with COVID-19. There's a double work for the administrative staff. Many of the administrative staff I find are actually going out and doing visits that they haven't done for many years. The managers are burning out right now because of, again, the virus that we've encountered recently. And so many of the administrative staff are actually going out and doing visits for the clinicians, that they're either losing some of the clinicians or also getting ill. So we have a reduction in the number of staff members that we can depend on. And then again, the turnover was caused by personal reasons, whether they're just tired, they just get burned out. Much of the burnout has to do, and we're going to talk about this a little bit, but much of the burnout has to do with an improper orientation, improper training, not understanding how to adjust their drive times, have their patients scheduled so that they're in close proximity, and then not having a work-life balance. And I think that's really, really important that administrators, administrative staff, and home care agencies understand that there is life outside of home health and hospice. And you need to encourage the staff members to utilize their time wisely and get a balance of both of those things. So these are some of the direct quotes that we got recently from nurses as to why they actually left home health. The paperwork is lengthy, and it is a lot of paperwork, and it's different than what we find in hospitals and other healthcare settings. Most of the hospitals are charting by exception. With us, we have to chart what's actually being seen, and part of that has to do with the patients are not in four walls. The patients are all over, and the surveyors and the auditors, when they come in to audit, Joint Commission, CHAP, ACHC, when they come in to audit, they can't actually go into a room and see what's going on with the patient. So our paperwork is the thing that is going to substantiate what we actually did in the home. So the paperwork is longer than most healthcare settings. Orientation is inadequate. I've had nurses come from hospitals that I've interviewed and I've actually done training with, and they've told me that they came to home care because the hospital work was getting just too hard, and they want something easier. And I thought, well, this is the wrong place for you to be if that's what you're looking for. But I do believe that orientation, if it's done well, and the ongoing training, and that's our next point, that the training is poorly structured. The training is structured for these staff members or these nurses coming out of the hospital. I think you're going to have a much longer retention, and the nurses are going to be much more satisfied with their job. Workload is equivalent to 2 full-time jobs. Again, part of that has to do with clinicians taking notes in the home and not getting their point of care documentation done. Documentation requires too much time. Again, part of that has to do with the lack of orientation and the lack of training, so they understand what they need to be doing with the documentation. So their advice to management, and these are nurses who have left the field, is to relieve the stress of the field staff. So whatever that takes, and as I mentioned before, that work-life balance is so important. And so being creative in how you might be able to maintain that with your field staff would be very, very important. Another item that was repeated over and over again was better training for employees. And I've seen that in the number of years that I've been in healthcare and home care specifically, is that agencies that I've worked with as a consultant and actually managed the agencies, if they provide the training and if they provide a proper orientation for their employees, they're much more likely to stay with you. So let's talk a little bit about telehealth. And we talked about issues in home health, but let's talk a little bit about telehealth and actually how it improves home health. So we're going to go into more depth with each of these, but avoiding LUPAs is one of those. With PDGM, one of our main criteria when we set up a case and when we have a case ongoing is we want to avoid LUPA at all costs. Occasionally, we're going to know that there's a LUPA payment coming. When we go to the no-bill wraps beginning January, the LUPA type cases that we're probably not going to completely avoid, because we're always going to have those types of cases that are going to fall into a LUPA status. But that's going to take on a different look as well, because we're not going to get that cash up front when we start seeing these LUPA patients that we know are going to be LUPA patients. Reducing risk to exposure to viruses. Again, we've seen this with COVID-19. We have patients who don't want nurses coming in. We have nurses who don't want to go out. So we have found an extraordinary use for telehealth and reducing the risk to exposure of viruses. Avoiding missed visits. This is something that I see going on even though PDGM is here, and it's here to stay, I still see a number of missed visits by a number of clinicians. And we're going to talk about how telehealth, it can actually improve that number for you. And then your QAPI results. Everybody wants to have excellent QAPI reports for your surveyors to take a look at. And so the QAPI results that we can get by getting documentation and getting data that is very objective from the telehealth program itself is extremely important. And then achieve objective patient outcomes. And again, the objectivity with telehealth is extraordinary. And I think that you would be very happy with it once you started using any kind of telehealth program. So what's the purpose of telehealth for your agency? Well, one of the things we look at is the reduction in cost. Because if we can do a telehealth visit, physicians have found this, it's going to be interesting when the PPE restrictions and those waivers are gone, because physicians are getting very, very used to using telehealth, and they're finding that they have a considerable reduction of cost and care in their own offices. But for us in home care and hospice, we can actually reduce care using telehealth. And I give you one example. Is again, for hospice, I think this can be extremely helpful. Many times patients in hospice get panicked, like over the weekends or in the evening, and you can actually do a virtual visit and actually see that patient and see if it's a patient that you actually need to go out and do a PRN visit for or not. Same thing in home health. We can actually visualize that patient and determine whether or not they actually need to be seen or not. So the driving cost, among other things, is one thing that can actually reduce the cost of care for your patients. Rehab management, we can do a lot of rehabilitation, particularly in home exercise programs. You know that patients who are on home exercise programs likely only do those when the therapist is there. So if we can put together a management program where the patient is actually getting a connection with the patient's actually getting connection from the agency to encourage them and to actually watch them do their home exercise program, you're going to get better results from your rehab program. Increased productivity, your nurses will find an increase in their productivity because there won't be as many on-site visits that they'll need to do, but they'll still get the same quality of outcomes for their patients and have still the same quality of documentation once they complete it. We can use telehealth for disease management. Many of the telehealth programs now have disease management programs built into them, and we can use that for teaching and a number of other things. But disease management programs built into the telehealth program is extremely profitable for home care agencies. Reduction of hospitalizations or rehospitalizations is really, really important. This really affects your outcomes. It affects your star ratings. And your star ratings are so important because not only is CMS looking at it, but many of the insurance companies are looking at that. And if your star ratings are 4 or less, many times they're not renewing these contracts. So the reduction of hospitalizations and rehospitalizations are really, really important. Improvement in patient satisfaction. Patients love being connected. And the improvement in patient satisfaction has been proven by many of the telehealth vendors out there. And there are a number of studies that show that patients are much more satisfied if they know that they can connect with someone. And it also, you know, right now, again, with COVID, we've got a real problem with loneliness with patients. So the loneliness issue can actually be improved using telehealth, particularly with remote care monitoring. And there are a number of, I know that Axxess actually has a connection with Connected Home Living that is a company that does remote care monitoring. So the improvement in patient satisfaction with that, knowing that they can contact someone immediately or very quickly is going to actually provide an increase in the number of quality star ratings that you get in your home health compare. Your ALF and LTC are limiting visits right now with COVID. So COVID-19 has actually driven the telehealth programs front and center for many of the healthcare operations. So ALFs and long-term care facilities for hospice are limiting the number of visits that can be done in their operations. And so using telehealth to get the same outcomes is very, very important. Conserving PPE. If we don't have to go out to the home, we're going to be able to save on our PPE. And as I've been reading in the newspaper and listening to the TV, it sounds like we might be in for a little more of a boost from COVID-19, if you can call it that. But it sounds like we're going to have to conserve our PPE as much as we can and make sure we have enough to support us throughout any additional pandemic issues. Infection control, of course, if we're not touching the patient, if we're not going out there, if we're doing things remotely, again, that's going to help us with infection control with not only our patients, but also our staff. The use of telehealth is cost effective. We can actually save money. We'll be able to reduce the number of on-site visits that are being done, yet maintain the same outcomes. We can use telehealth with management and evaluation, and I know a number of agencies have considered using management and evaluation and also maintenance for therapy. And so using telehealth to augment, again, those visits that might be done if you were going out there on routine visits is very, very helpful. And then the telehealth touch points for your disease management programs are exceptional. As I mentioned, many of the telehealth programs actually have disease management built right in. So the patient can have ongoing learning, even if the nurse isn't there or the therapist isn't there, by using those disease management programs. But the Tele-Touch points, where just letting that patient know that you're connected with them and that you care about them and that they have something to go back on if they do get lonely and they just want to talk to someone. It's just a really cool thing to have as part of your home care agency overall program. In determining what telehealth you want to look at, because as I mentioned, some of the programs are very sophisticated and they actually have remote care monitoring. They have 24-hour-a-day staff available for your patients that you don't need to monitor them, but the telehealth company actually does it for you. Or you have some that you can actually use your cell phone, your smartphone, and the patient can communicate with the home care agency that way. That's called BYOD. They can use their own computers or whatever. So you want to take a look and see what type of program you actually want. So look at the strengths of your agency and also the strengths of the telehealth provider that you're looking at and see if they're compatible. Weaknesses, the same thing. You're going to have to look at both yours and theirs and see if there's something. Now, there's some telehealth companies that may just not fit the bill for you. Maybe you want something that's much less expensive. Perhaps it doesn't communicate as much with the patient, but it does what you need to have it do, and your outcomes are the same. So your opportunities with telehealth is extraordinary as far as I'm concerned, because if a physician knows you have a telehealth program available and they know that they can communicate with that patient from their offices, you're likely going to get more referrals from that physician, and maybe even also the hospital and the discharge planners. I know a number of the discharge planners are actually asking if you have telehealth available in your agency. So it really is something that a lot of referral sources are looking at. And then what's the threat out there if you don't have telehealth? A lot of agencies are getting it, and a lot of them are using it in a very sophisticated way. So you want to take a look at, do a SWOT analysis of not only your agency and what the needs are there, but also of the telehealth company that you may be looking at purchasing or leasing or whatever type of payment program they have. So some things to look at when you're determining that telehealth program availability would be policy. What kinds of policies are out there? Regulatory policies with conditions of participation and also payment. As I told you before, we can only do administrative costs on our cost report, so we actually aren't paid directly for the cost of the telehealth program. However, regulatory-wise, we need to take a look and see not only what the policies are as far as the surveyors are concerned, but also our internal policies. So we need to take a look to make sure that we have, if we're going to use telehealth, that we have policies to support it. For instance, surveyors want to see that you have, we don't have a lot of information about it, but surveyors want to see that you have orders on your plan of care or on a change order for telehealth, how often you're going to see them. I almost think that you need to look at telehealth as another discipline in your organization. So it'll be very helpful if you really lay that out very specifically at how often you're going to do it. Build in some PRN visits for yourself. We could do a whole another session just on that and how you actually use telehealth once you get it in your organization. Making sure you have proper consents. You're going to have to make sure that your consents allow for that, allow for the video, if you have video with your telehealth program. So just like you have photography consents, you're going to have consents for this as well. And again, we have certain waivers with the pandemic. We have waiver policies that will go away once the pandemic ends. But you got to make sure, you want to make sure that you know what those waivers are for and what they actually cover. So with the equipment, you're going to have to, again, look at the cost of the equipment, what type you're going to get. Are you going to get remote care monitoring? Are you going to do the remote care monitoring? Or are you going to let the telehealth company do the remote care monitoring? And any kind of alerts on the equipment. You want to make sure those alerts are set appropriately. I found that some of the telehealth programs have alerts that are so narrowly designed that you're getting alerts for all kinds of different things, and the physician's getting alerts and they aren't happy with that. So make sure that those alerts that are set up on the equipment, if they have them, are set so that they're not going to be difficult for people to live with. As far as your staff is concerned, you want to make sure that they have the actual training. Make sure they understand what model you're using as far as the telehealth is concerned, and that there's oversight of the telehealth program in general in your organization. Budgeting wise, you're going to find that your LUPAs are going to change, that you will not have the number of LUPAs that you had in the past if you're using telehealth. your gross margins, you may see a reduction somewhat in gross margins as far as expense of the program itself. However, you actually may see an increase in your margins because you're not doing as many on-site visits and you're not paying for things you normally would if you're actually having to do an on-site visit. Again, we talked about reimbursement, that reimbursement is not here yet, but it is coming. Susan Collins has a bill in the Senate right now, and we do believe in 2021 we are going to be able to get somewhere. I know that Bill Dombey is working really, really hard, and I'm sure Warren at your state association is working hard too to achieve that purpose and make sure that we get some kind of reimbursement for telehealth, because we know how important it is now. COVID has taught us a very valuable lesson as far as that's concerned. Your visit notes, your software in your that you're using now, you want to make sure that there are visit notes built into the software. I know that Axxess has a very exceptional visit note for their telehealth visits that are being done, that are built into their program. So you're going to want to look at your EMR and make sure that you have visit notes and they're well documented, their telehealth. One thing you don't want to have happen is have your biller actually bill for one of the visits that were done via telehealth, and it wasn't actually a visit, an on-site visit that we can't get paid for. I don't know if you've heard this, but there are a number of infection control surveys going on right now, and one of the things the surveyor asks is whether or not you have telehealth and how you're billing for it. And it's kind of a trick question, I think, that surveyors are using. So one of the things you need to say is we aren't billing for it, but the other thing is to show them what visit notes you're using and how you identify it as a telehealth visit as opposed to a routine visit, so that there's no mistake in billing. You don't want to ever be caught with fraudulent billing, and that's what that would be if you billed for a telehealth visit as a routine visit, that it is not. Your plan of care, make sure that your software has a way to develop the plan of care. I already mentioned that your orders for telehealth should be set up almost as a different discipline. So you indicate the telehealth program you're using, how often you're going to use telehealth, and build in some PRN visits for the program. And then use it as a part of your care path. This can be used to get to the patient to positive outcomes. So some of the care pathways actually include telehealth in them. If yours that you're using does not, I would encourage you to take a look at them and possibly reconstruct your care pathways to include telehealth if you're going to use it. This is an example actually taken right out from off of an Axxess client's report, which shows a patient who has a cardiac case that's late community, low comorbidity and mid-functional, that actually ended up with a $647 margin because they use telehealth. You can see that they use telehealth to augment their skilled nursing visits. Another way you can augment them, of course, is your home health aide. You may not need your home health aide as much. You may put more home health aides in than nursing for them to report to you, but you may not need as many nursing visits. And then you can also build in PRN visits for that use as well. But this would change your LUPA threshold by the utilization of the home health aide in here, so that we end up with a $647 margin. Cost of a single LUPA, again, this is a loss. This is an example, and here, this is a screen right out of the Axxess program that shows that there was a LUPA adjustment for this particular case. There weren't enough visits that were seen to prevent the LUPA, or the patient wasn't seen to prevent the LUPA. There were only 4 visits in the first 30 days, and apparently they needed more than that to avoid it. So they had a loss of $1,265. So using telehealth to avoid some of those LUPAs and again, augmenting your nursing visits with home health aid and telehealth is very helpful in avoiding those revenue losses. This is some information on your telehealth provisions, some of the waiver provisions that I won't go over this in detail with you, but you can see that with home health and hospice, we can do face-to-face visits. So the physician face-to-face visits for now with the public health emergency would be billable, and it has to be a two-way visual. So as I mentioned before, if you have that ability, this is a really good marketing tool to take to your physicians and also your discharge planners and show them that you have that capability of visualizing that patient on an ongoing basis. The initial assessment for home care and hospice, now don't confuse that with an OASIS assessment. You can't do an OASIS assessment or an integrated assessment over the phone, but you can use telehealth to do the initial assessment as far as determining eligibility and that kind of thing. So it does tell us that we can use that as part of the waiver. But again, all of these things are going to end at the end of the public health emergency. Visits on the plan of care, and then home health aid supervision for both home care and hospice can be done by the use of telehealth during this public health emergency. The timing hasn't changed. It's still every 14 days. But again, it's very, very helpful during this time so that it prevents us going to the patient's home when we don't really need to. Again, you can determine the homebound status, and that's all part of your patient eligibility. So here's some other items that you can take a look at as far as waivers are concerned and the use of telehealth and how it can be advantageous to your agency. So again, this use of telehealth has really, really surged between 2019 and 2020. It's gone up from 11% to 46% just under consumers. So folks are getting a lot more information. Again, the politicians are talking about this. Your congressmen are talking about it. CMS actually, CMS has actually come out and said that they would like to have the telehealth paid for, but it's going to take an act of Congress. So if I were you, I would be reaching out to your congressman and encouraging them to do something so that we can get paid. Again, make sure that you support your national and your state associations, because I know that they're working hard to get this paid for us. The use of telehealth has increased from 11,000 units to 1.3 million among beneficiaries. So even this, these ads for a place for mom and that kind of thing, they're encouraging the use of telehealth for a lot of these patients that are confined to their home. Again, telehealth viewed more favorably by 57% of providers, and 64% are more comfortable with using it than prior to COVID-19 in the year 2020. CMS has launched 80 new types of telehealth services, so they're allowing for many, many more types of telehealth services to be utilized in the healthcare community. Tele-Doc provided 2.2 million visits alone in the first quarter of 2020. That's 77% year-over-year growth. So just take a look at that, and so you can see physicians are actually adopting this much more quickly, I think, than many providers are. CMS actually recognizes that the healthcare services following the patient, regardless of their setting, is improved with the use of telehealth, and then $250 billion in U.S. healthcare spending could be potentially virtualized. So they're doing ongoing studies right now, so they know that the use of telehealth is going to reduce the cost of healthcare. So it's actually telehealth accelerates the achievement of triple aim for CMS. So they're working really hard to explore ways that they can use that to reduce the overall spending of the healthcare dollars in general. So the number of seniors in Medicare using telehealth shot up. CMS relaxed regulations among the pandemic. So just look at this, March 7th, there were only 11,000 providers using telehealth, and April 18th, and I'm sure that that's much higher now. We didn't update this graphic, but it's much higher even now than it was on April 18th, with over 1 million providers using beneficiaries using telehealth services. In the past 2 weeks, this is the use of capable devices, video capable devices. Now, most of you have a smartphone, or most of the patients either have a smartphone or a computer in their home. So this was just a study that was done in just this past year. In I think March 25th through the 30th, I'm sorry, it was very light print there. So in the first study that they did, in the past 2 weeks, have you used a smartphone, tablet, or computer to talk by video to your doctor or healthcare providers? So 11%, only 11% said they had, the patient 65 and over. The second question was, in the past 2 weeks, have you used a smartphone, tablet to talk to video friends or family? In that, 38% of those 65 and older gave a more positive reaction at 38%. So we know that it's being used, and we know that we can teach our senior citizens how to use that to improve their health care. So another question that was asked is, did you have a favorable or unfavorable response experience with use of telehealth? And 53% of people that use telehealth during a short period of time said they had a positive response to the use of telehealth, and only 2% was unfavorable. And that had to do with the actual orientation of the patient on how to use it, and your staff members' acceptance. So some of the staff members, of course, you know, we as nurses, many times it's hard to convince us that we need to change something. So some of that had to do with that, but if they were trained correctly and the use was done as intended, the favorable rating was very high. Missed visits, we talked about that a little bit. Having missed visits, particularly with PDGM, is extremely, extremely costly. So using some of the alerts that you can put in with telehealth and in your scheduling, and as I mentioned, you schedule these kind of like a discipline. It can give you alerts and warnings so that you can change your habits with your LUPA problems and your missed visit problems. So avoiding missed visits is going to improve your outcomes. Again, if a patient isn't getting their visits there, you're certainly not going to achieve outcomes that you expected in the beginning. And then, of course, it also decreases your LUPA status. So the missed visits are really important. You can connect with that patient right up until the time the clinician arrives at the home. You can see what's going on, and those missed visits can be very minimal. So some of the public health emergency changes is regulatory waivers. Of course, they've expanded the healthcare system's workforce. They're allowing many of the healthcare providers to work over state lines now. Increase local hospital systems capacity. They have hospitals without walls. They've actually, you know, during the real crisis that we had right in the beginning, we even had ships coming in, and we had tents being set up and that kind of thing. So there is an increase of the availability of healthcare with regulatory waivers. Increase to telehealth and Medicare. Again, they actually started encouraging us to use telehealth. Again, no payment, but we're working toward that. And the more you use it, and the more numbers they see coming through on cost reports, they at some point are going to have to decide they're going to have to pay for that. Expanding of inpatient place testing, and then enhancing patients over paperwork. That's a theme that we see throughout the CMS documents, and they're talking about, like I said, the Paperwork Reduction Act and that kind of thing. Telehealth does do some of that for us, but certainly waivers that we've experienced since the COVID-19 has really enhanced the use of telehealth, and overall all these waivers have been very, very helpful for all of us. So purpose-driven encounters, if we see these patients, again, as I mentioned earlier, the use of telehealth in intake, I think, is exceptionally important, because we could actually see what's going on with the patient, and making sure that when we go to the patient's home, we have a plan in place, and the patient has a plan in place, and the caregiver or the family members actually have a plan in place. The Tele-Touch actually will improve the outcomes, because that patient has access to a clinician on an ongoing basis, and it will actually improve your outcomes overall. Your QAPI results, we can get, as I mentioned earlier, I think the objective data that we get from telehealth can really make our QAPI results shine. Our vital signs are not going to be skewed by monitors that aren't working well or that type of thing. Our vital signs are the vital signs that we get. And so off the telehealth program, the disease management teaching guides that we get are going to help with QAPI, because the patients are going to be much more knowledgeable. So the results of our visits are going to be improved. The goal orientation, so that our patients are going to be able to achieve their goals. Your health indicators, again, are going to be more objective, and you'll be able to report to the physician, and also to your surveyor and your reports for QAPI objective data. Your video assessment and demonstration of skills, the telehealth can be used for that. And so I think that achievement of some of the teaching that we're trying to complete before we end an episode is much more doable because if we can have more access to the patient on a more frequent basis. You're not going to be able to go out to the home multiple times a week, but you certainly can do a video with the patient multiple times a week. And then patient return demonstrations on home exercise programs. Some of the therapy companies are getting very creative with telehealth. And so the results that we're seeing in therapy are pretty incredible. So your QAPI results are going to be improved as a result of that. So Telehealth Now and Beyond. So pre-COVID, we said that we had 11,000 folks on it. The future, we're going to see more of a demand. People are getting more, family members and patients themselves are getting more educated on the use of telehealth. They aren't necessarily going to want to go to the doctor as much as they used to. We see an expansion of the waiver probably into 2021. And as we know, that the technology is changing all the time. So the use of technology and use of telehealth is expanding. Post-COVID, 650,000 Medicare weekly encounters. We're going to see face-to-face allowances. We're hoping that, again, the face-to-face with the clinicians, I'm not talking about physicians, but with clinicians will be allowable after COVID is over. We're certainly hoping these bills are going to get passed that are in the House and the Senate right now. And then many of the Medicare Advantages, I've been seeing ads on TV now, many of the Medicare Advantage programs are actually paying for telehealth. So if you have Medicare Advantage for some of your patients, you might want to check into that. 64% of the agencies right now, as we speak, are using some sort of telehealth. Now, some of the agencies are using telephones, quote unquote, as telehealth. And there's some limitation, well, quite a few limitations in that. So part of that 64% includes the use of a telephone resource, but actual telehealth where you can actually get data, you can receive data, you can actually visualize the patient with remote care monitoring, that kind of thing, is possible. Hospitals, ACOs, everyone's seeing the advantage of the use of telehealth, and so they're actually encouraging it. Hospitals, when patients are being discharged, they're asking the patients if they have access to telehealth once they go home. And again, reducing the hospital rates themselves and rehospitalization rates and the emergency room rates, I think, are very significant with the use of telehealth. So this will be clearly part of value-based purchasing, having that data that's going to be able to be used to improve the post-acute care setting care of patients is going to be significant, and even after COVID. And I think that we need to be start looking at what type of telehealth, not if we want telehealth, but when we want it and what type of telehealth we want is going to be significant. Here's some more information. In fact, I believe that's a duplicate slide, and I apologize for that. But future considerations, the post-acute for telehealth, I think, is going to be something that we're going to see just as we see PT, OT, skilled nursing, home health aide, social worker. I think that for providers in the community, I think everyone's ready for it. And we just have to figure out how we're going to get paid for it. So considerations, again, long-term considerations is actually hanging on to your staff and not having the constant turnover of your staff. It's kind of like, I told someone that I was working with a telehealth program once, kind of like having a patient in your pocket. You can pick it up, pick out your phone and take a look, dial in, and you can actually see your patient. Same thing with the patient. They're going to be able to have you in their pocket. They're going to be able to actually see you and be able to talk to you and get your expertise on different things. Technology and equipment, again, you're going to have to determine what type of technology. I hope I've given you some tips on what to look for when you're actually going to use a telehealth program. And then your patient outcomes is going to affect your spend rates on healthcare. Telehealth is going to decrease your spend rates on healthcare in general. And then the evolution of healthcare, telehealth is just a natural part of that evolution. We're going to see this used more and more often. Physician's office, I think they're hooked now. I think it's something that they're probably never going to get rid of in a doctor's office now. They'll be able to actually see more patients in the care in clinical care situations. They're able to see patients on a dime. They can dial into a patient and see them right away without having to send them to the emergency room for a possible rehospitalization. Doctors want to keep those patients out of the hospitals as well. So I think the physicians are already hooked on the use of telehealth, and I think that the providers will soon have that same experience. So again, watch your legislation. We do have a couple bills in the House and the Senate right now. And as I mentioned before, your state and national associations are working on that. Look at your technology. What do you want in your organization? Do you want to spend time actually doing the telehealth or remote care monitoring yourself? Or do you want to look for a service that's actually going to do that for you? A number of years ago, we had several different types of telehealth going on. And for many, many years, I know agencies that purchased the telehealth technology and they just set it on their shelf and never used it. I think that now we're finding that there's a real benefit in having it. And so these units are not going to sit on a shelf. They're going to be utilized quite a bit. So again, this is going to reduce your spending, your actual spending, and change your budget in your organization. It's going to improve your outcomes and augment staff. So again, use that SWOT analysis that I gave you to actually determine what types of telehealth you want. And if you have any questions, you can actually reach me here. And I've done quite a bit of research on telehealth programs themselves. As I mentioned, Axxess has partners with telehealth, and they actually have the visit technology and that type of thing for it. So, so we're well equipped to go into the future with this. Well, thank you so much for your into this. And if you have questions, I believe we're going to have a question and answer period at a later date. And I will talk to you then. Thank you very much to the association and for those of you who listened.